I think what's really cool about rehab after dorsal rhizotomy is I think a lot of the rehab things we do is going back to the previous function and what you did before.
Mm.
But I feel like this is different. You're
Hmm.
learning a new skill, you're gaining new muscle strength and alternative ways to do it. And I find that really fascinating and encouraging. Like, how often do we get to do something like that?
Yes. How often do you intentionally cut or disable a portion of the central nervous system, or technically speaking, the peripheral nervous system? But still, how often do you get to do that and help people gain function?
Right,
So
right.
it's a unique surgery
Yeah.
within neurosurgery for sure.
Welcome to The Summary, a podcast from Mary Freebed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
Today, we are excited to talk about neurosurgical treatments for spasticity in kids and adults. And we have a very special guest here, Dr. Casey Madura, who's Section Chief of Pediatric Neurosurgery at Helen DeVos Children's Hospital, which is a mile or two down the road from us at Mary Freebed. So, Dr. Madura, welcome. Thanks for joining us.
Yeah. Thanks for having me. Happy to talk about it.
So we'll start with, I guess I want to start with what are some of the reasons we want to treat spasticity? Because just because a patient is spastic doesn't mean we necessarily need to treat it. We need some reasons, and those can be functional reasons like moving the arm better, reaching out better, walking better. It can help with dependent care. So patients who are non-functional, making it easier for the caregivers to dress them, change them, transfer them, help with sleep, help with pain, especially in kids, help minimize the progression of joint contractures. So I'm a pediatrician, so I'm going to start with selective dorsal rhizotomy,
Okay, that sounds fair.
which I think has been around for about 100 years.
Yes.
So-
Over 100 years, 120 years.
Okay. So tell us a little bit about selective dorsal rhizotomy.
Sure. Yeah. It's as we said, it's been around for a long time. When it was first done, the answer was to cut all of the roots, and there was a reason that when that's what was done, that they stopped doing it for many, many decades, and then it was eventually, discovered that it can still be effective, but you don't have to cut everything, and that really was the turning point for bringing it back and repopularizing it. The primary neurosurgeon that really pushed this was Dr. T.S. Park in St. Louis, and he did a lot of what are considered kind of the groundbreaking studies to show that this is valuable. This was in the 90s and early 2000s. And I think I would echo some of the things you would say. And then also in terms of why you do a rhizotomy, what are you trying to accomplish? But also it's pretty clear that doing them early, if you can, is good, because it doesn't prevent orthopedic intervention, but it certainly lessens the severity of what might be necessary. So instead of having multiple, derotations or tendon releases or whatever it might be, you might only need one. And instead of maybe a big multi-level surgery, maybe you only need it at one joint or something like this. So the idea is, we know that selective dorsal rhizotomy for initially children who are spastic, diplegic, who we knew would eventually develop joint complications longer term, we knew that intervening early was good.
How early is early? Like, how do you determine when to do that?
Classically, it's as early as 3. The sweet spot for kids seems to be anywhere from 3 to 8. But I can tell you, like, Dr. Park would do these as early as 2. There's some controversy about that. And I think the controversy largely is that how can a 2-year-old follow directions? How can you do a therapeutic program with a 2-year-old. And there's a big difference between a 2-year-old, even 3-year-old. I mean, my own 3-year-old, no way that she could have carried out a program, but I've met 3-year-olds who absolutely could have. So I think largely it has to do with participation, because I think for us, we know that you do a rhizotomy and families have a huge focus on that because it's the surgery. But the rhizotomy is really like this one little tiny piece of their overall care. And I think it's only after the rhizotomy that they realize how much the patients have to put into it. And that's why you need the kids to be a little bit older. So for us, we try to get them between age 3 and 8. But we've done them for children. I think we've done one, if I recall correctly, for somebody as young as 2.5. And I know we've done a rhizotomy for a patient who was in their 6th decade of life. So we've done the whole range.
Wow. What's the reason for the younger than 8 then?
I think it's just that doing them early, the way I view it is the earlier you do it, the less behavioral imprint you have so that you can retrain gait easier. You have less contracture so that you're not fighting against that. And potentially you have less pain. So I think for those 3 reasons, the age isn't as important to me. What I need to see is, do we have a patient who can participate, who we think has good strength, and is the family ready?
Yeah, and in those types of patients, they're ambulatory to some extent, a lot of times with a walker, and a lot of times they're weaker after the rhizotomy initially. So that's one of the reasons we do the intensive rehabilitation, often inpatient rehab for a while, but then even fairly intensive outpatient for perhaps a year. Ideally, the patient is, 3 to 8, but also doesn't have significant cognitive impairment, so that they can actively participate in therapies if they're walking. And we'll talk about rhizotomy in less functional kids as well. But in the typical kid that you mentioned, they're typically premature, spastic diplegia, periventricular leukomalacia, and that I agree 3 to 8 is kind of that sweet spot. And it's pretty much a lifelong. I mean, some of this tone might come back a little bit, but I've seen many patients 10 years out, they still have a significant reduction of tone compared to where they were.
Yeah.
And then, another advantage of that is we're not giving generally spasticity medications or doing Botox injections. And sometimes they still need some orthopedic surgeries.
Yeah.
Is it common typically to need a few other surgeries as the child grows after the SDR?
Yeah, I think so. I mean, I would love to say that our surgery is a, one stop and you're done. But the reality is that this is sort of it's a lifelong issue, right? I think that's maybe where sometimes the expectations aren't quite aligned, which is the surgery it's a great surgery in the sense that it's not a mystery. We know that when we do the procedure that the tone is going to reduce, right? This is not one of those surgeries that you say, well, we'll do it and 70% of the time it works. It works. The question is, how long is it going to work for and what comes down the line? And a lot of that has to do with how committed to the extra stuff the family is. And I think the most important thing that I stress when I talk to families about it is that I try to sort of demystify surgery, because the surgery is very straightforward. It's a very low complication surgery relative to some of the other things that we do. And there's actually a lot more work afterwards. And I think before surgery, everybody thinks that the surgery is going to be the hard part. But I haven't done this, but I bet you if we surveyed families who've been through a rhizotomy and you asked them, what was the hardest part of your care? I am quite certain it would be flipped. It wouldn't be the surgery anymore. Instead, it would be the commitment that is required of them to maintain stretching, maintain activity, because this is not something that you can just have done and you're done. You have to keep working on it.
Yeah, and patients recover pretty well
Yeah.
from the surgery. And I mean, you do a laminectomy, a couple. What do you do? Like a 2-level or so?
Yeah, right now it's mostly single level.
Yeah.
We can talk a little bit more about that. I mean, when I started, I trained at Alabama, and that's what we did at Alabama, and so that's what I did when I started here 10 years ago. And then just from an invasiveness standpoint, it sort of became clear that I didn't need the 2 levels, so I've transitioned to doing just one for the dorsal rhizotomies. We haven't talked about it yet. For the palliative rhizotomies, those I still do 2 levels because I find the extra exposure is helpful. But it's, functionally for a patient, you're talking about the difference between a incision that's maybe 2 inches to an incision that's 3 inches. So it's not a huge difference between the two.
And they come over to inpatient rehab like at day 3 or 4, right?
Yeah. In a perfect world where we didn't have all the insurance issues,
Yeah.
They would come over on day 2, post-op day 2, but that's not the way it usually works. And
Yeah, but even then they're pretty mobile.
Yeah.
They're not uncomfortable.
Yeah. So, we have the benefit of operating largely on kids. So kids have smaller back muscles, so they don't hurt nearly as much. It's pretty clear to me that there's a psychology that we learn about how we should act when we're in pain. Because the same pain that a kid might experience, they just sort of acknowledge it and move on. Whereas adults we have a tendency to sort of feel sorry for ourselves, and that does not help in recovery. So kids just recover faster. And that's true across surgery. That's not specific to rhizotomy. That's true. I mean, we just did a surgery for an 11-month-old who took off half of the skull. And this kid is going home on day 3.
Wow.
Right. If we did that in an adult, we'd all be in the hospital for a couple of weeks. So kids just recover faster. So for me, and this varies from surgeon to surgeon. There's usually a period, you do the surgery, there's usually a period of time where a patient lays flat. They can roll side to side, they can lay on their stomach if they want, but the idea is to keep head and hips at the same level. This has been studied. There's no difference in outcomes whether you keep them flat for 24 hours or 48 hours or 72 hours. But I can tell you that every surgeon does what they do. For me, I do the surgery. I have them lay flat until the next morning. And I tell families, when you wake up the next morning, you can go. There's a lot of reasons for that. One of the main reasons is that in order to get them here, we have to start the process for insurance approval. But in order to start the process for insurance approval, we have to have therapies work with them. And therapies don't want to work with patients who can't get up. So do the surgery. We often do these on a Tuesday. Therapy evaluations Wednesday. In a perfect world, insurance authorization Thursday, and they come over to Mary Free Bed. Sometimes Friday, sometimes over the weekend, occasionally even longer than that. But it's all based on whether we have approval. And I think only once in the 10 years that I've been here have I ever heard something like, "Oh, we don't have a bed for the patient." Thankfully, that's not an issue. Where it is, that's an issue many places. University of Wisconsin, where I did my residency, there was no inpatient rehab anything anywhere close. So actually, the patients who got the rhizotomies stayed in the children's hospital for 6 weeks. On the acute floor.
You said it always works. It always reduces tone, and I would agree, but it's also based on patient selection.
Yeah.
So sometimes we see these patients who we're not quite sure about, and we have a conference here. We meet with you guys, you and your partners, orthopedic surgery, neurology, ourselves, physical therapy, do these evals, show videos up, and everybody looks at the videos, and we talk about what we think is the best for this kid. Tell us about some of the kids who we are a little leery about doing a selective dorsal rhizotomy on.
Yeah. So I think one of the things we assess is whether or not the kid has strength underneath, because I describe this to families is their child has learned to walk in part because of their spasticity. So the reason they walk the way they walk is because of the way they are. And the surgery is going to change that. It's going to take away that tone. But if they don't have strength underneath, you're not doing them any favors. So if they have no ability to build muscle and to have strength to do the things, then taking away the tone can be harmful. So now the hard part about that, of course, is in a 3-year-old, like they might be weak at 3 years old, but if you give them training and, they can gain strength. So that's always a balance. So super weak kids we worry about. I think expectations need to be realistic, right? We're not trying to say that we're going to make the kid walk normal. They're still going to have abnormalities in their gait. So every once in a while we have families who come in and they make that statement, I just want my kid to walk normal. And we have to go to great lengths to explain to them, like, that's not realistic. That's not going to happen. If we as surgeons can't be sure that families understand that, we will not go forward with a rhizotomy. Another one is spasticity is what it's meant to treat. It's not meant to treat other types of movement disorders, specifically dystonia. So there are some kids that have either predominantly dystonia or maybe a mix of the two. And we worry about those kids. The kids that, in my experience, have had outcomes that are not as good or might even be counted as failures, it's almost exclusively the population of children who had more dystonia than we thought. So I think those are the big ones. And then the commitment to the surgery. So we have to know that the families are going to participate, that the patient's going to participate, because otherwise, the benefit is super temporary. Now, that's a relative contraindication. If the child's going to suffer if you don't do surgery, but you also know the family's never going to commit to the surgery, does that mean we're not going to do it? Maybe not, right? Because that would basically be withholding a treatment that could benefit, even if only temporarily. But we work a little bit harder in that case to bring people along pre-op before we do it so that we can get the best outcome.
For kids who have more dystonia than spasticity or like a higher effect, how do you manage that patient population then?
Yeah, I mean that's a whole can of worms, but and that's the population that more often gets a pump, baclofen pump. You can manage dystonia depending on the origin of the dystonia. That's where deep brain stimulation can come in. And then we've had a few patients on the more severe side who've had all of that. We have one in particular who has a predominantly dystonic but partially spastic cerebral palsy in all 4 limbs, has gone through DBS, has gone through a pump, medications, Botox, I mean, everything under the sun, and nothing worked. And so then we took him back to the OR to do a what I call a palliative rhizotomy, where we're trying to section not just the sensory roots, which is what you do in a typical selective dorsal rhizotomy, but also the motor roots at the same time. And I would say there's overall less experience with that. So I don't know that we can say we know the outcomes. What I can say in that one patient is that the outcome has been moderate. It's not been a miracle. It's not been a complete failure, but I think we're still learning about how to apply rhizotomy for these non-traditional patients.
But you feel it's been better than the other treatments that have been tried?
Yeah, I think so. Yeah. The other treatments had no impact whatsoever.
So I'd like to compare and contrast selective rhizotomy with pump, and then later with the ventral dorsal rhizotomy. We mentioned the pump a little bit, which is surgically implanted pump the size of a hockey puck that goes into the abdominal wall with a catheter to the spine, and it infuses baclofen into the spine, where you get much more reduction in spasticity compared to oral baclofen. But that's, surgically implanted. You can adjust the dose. You need refills, and then every 7 years you need to replace the pump. Talk about, I guess, some of the pros and cons of selective rhizotomy versus a pump, in maybe that, again, with the pediatric population. So now we have to be a little bit bigger. So, say a 5-7 year old diplegic rhizotomy pump.
Yeah. I mean, I think it's important to acknowledge that my professional bias is very much in favor of rhizotomy over pump. So that being said, I will try to sort of go through them as objectively as I can.
Is that your disclaimer for
yeah, well,
lecture?
I think it's important for, people to be able to know sort of where I stand so they can interpret what I'm saying, but that's all. I think it starts with the family, because a rhizotomy is a procedure. You do the procedure and you're done with the procedure. There's no life-threatening complications if the family doesn't choose to do anything. Okay. Meaning that and choose is a bad word, because I think too often we sort of make it sound like it's that easy, and maybe a family has to work or they don't have access or whatever. I mean, there's 1,000 reasons that aren't anybody's fault. But the reality is the benefit of a rhizotomy will only be temporary if you don't have family participation.
Less kind of user error almost.
Yeah. A pump is a completely different story. If you don't maintain the pump, meaning family doesn't show up for a refill, or the pump doesn't get replaced when it should, or the family doesn't have access to somebody if they have an acute illness, baclofen withdrawal is life-threatening, or it can be. And so the biggest con of the baclofen pump compared to the rhizotomy is the upkeep that is mandatory. Like, there is no option to not do it, because otherwise the patient who has the pump that isn't working correctly for any number of reasons, their life is in danger. Whereas with a rhizotomy, you do the rhizotomy, maybe you can't do it, the patient's going to be fine, just not get the results. That being said, the pump is reversible. There's nothing about a pump that, when we put a pump in, doesn't mean you can't take it out. Rhizotomy is irreversible. And I would say that aspect of things is usually the point where families decide. Some families really don't like the idea of doing irreversible things, and other families don't want the responsibility associated with the pump. You have to be big enough for a pump. We have a few patients that probably have needed a pump or a rhizotomy years ago, but they just, one in particular comes to mind. They're just too small. And you have to, the smallness is between the pelvic brim and the rib cage. You've got to have enough space so that you can move around. And then the other advantage of the pump is that you can impact both arms and legs at the same time. Whereas with the rhizotomy, if you're going to impact the arms, you need to do a rhizotomy in the neck. If you're going to impact the legs, which is much more common, like 99 to 1, you're going to have to do it in the lumbar spine. But if you want to do both, you have to do 2 surgeries. Whereas a pump, single surgery, and you're done. And then I suppose the last con of a pump is the literature is all over the place. You can find papers that say the complication rate is 3%. And then a recent paper from a center out west, a very well-respected center, and I think they were doing their best, to be honest, basically cited a complication rate of 72%, right? 3 out of 4.
Wow.
And I don't think...
Wait, which was this for?
For a pump.
For
pumps.
Okay. Mm-hmm.
I don't think it's 3%. Like, I think that's being dishonest. I think 72% is where you count everything. Like
constipation.
Yes. Yeah. Right. You go out of your way to include everything. But I think what you really should interpret from that is that baclofen pumps are prone to complications, and rhizotomies, as big as the surgery sounds, almost never have complications. Almost never. So now all the complications that are typical in a pump are treatable. So, things like the fluid, the cerebrospinal fluid that goes around the catheter can leak out the wound. It's an implant, so infection is an issue. Those are almost all treatable. The only ones that can be a problem is baclofen withdrawal. But as long as you have appropriate recognition of that, and we kind of go out of our way to educate patients about it, then you can do it. So I don't want to make it sound like the complications are dire. They're not, but they're frequent. You just have to manage them.
I think one really interesting thing that I heard from a parent with a child with baclofen pump is that every time I go to the ED for whatever reason or see a doctor for whatever reason, the first thing they will say is like, oh, this is because of the baclofen pump.
Yeah.
Yeah. And that like complicates the time and everything quite a bit. So, yeah.
Yeah, this is a cognitive bias that we all deal with. Every physician deals with this. And recognizing it in yourself is very hard, but it's exactly what you just said. This is called a framing bias, right? You have framed the whole scenario because you said this patient has a baclofen pump. But there's just no way around it. And I suppose in some respects, that's not a terrible idea, only because baclofen withdrawal, if you miss it, can be a huge problem.
Mm-hmm. That makes sense. So. Yeah. When you do dorsal and ventral rhizotomy,
Mm-hmm.
First of all, I've never seen the surgery itself myself, so I'm very curious of that. But when you're determining the percentage of the rhizotomy, do you do less if you're doing both on like both sides?
No, actually you do more. And you do more in part because the patients that we've done this for are, generally speaking, non-functional. They're the ideal patient for a palliative rhizotomy, where you're cutting both dorsal and ventral, is a patient who is spastic quadriplegic, who does not participate with their legs or their arms, if you're doing a cervical rhizotomy, who does not participate. The tricky ones are the ones who maybe can walk a little bit with a gait trainer, with a very robust gait trainer, but otherwise are in their chair all the time. So those kids are the gray area. But the ones we're doing the palliative rhizotomies for so far are non-functional and non-participatory. And it's all about comfort. It's all about comfort, and then reducing orthopedic intervention in the future, because a lot of these kids have had orthopedic intervention. But if all you do is derotate something or transfer a tendon somewhere or lengthen a tendon somewhere or whatever, but the driver that caused it to be a problem is still there, which is the spasticity, there's a tendency for whatever was reversed to revert back to what it was pre-op. So the idea is to take that driver away, so that then often you might take a kid who had serial casting before that worked for a while and then didn't work. You do the rhizotomy, and now the serial casting will not only work, but be durable. So yeah, but for those anyways, to answer your question, I mean, I guess the literature that's available, and it is scant, but the literature that's available suggests cutting 80 to 90% of the roots, whereas
Of both.
Wow. Whereas the literature that I'm aware of, and this does depend on who you're talking to, some people believe you should cut about 2/3 of the dorsal roots if you're doing a dorsal rhizotomy. My partner has data from his work that suggests it should only be about 30%. So there is disagreement about exactly what to cut. But I was trained 2/3.
Sounds like a good opportunity for a study right there.
Yes, yes. It's a difficult study for a lot of reasons. The main reason is it's not so simple to get perfectly even branches of, perfectly even rootlets, so that it's very subjective in terms of the surgeon saying, I believe this is 1/3 or I believe this is 2/3. That part is, you'd have to have some sort of like camera that could quantify exactly what percentage of the root you were cutting.
So it's all by feel.
I mean, you can see it, but there are certain planes that are just sort of open up, and you risk causing dysfunction if you sort of force it. So sometimes you might take one root, turn it into 3, and they might be slightly different from each other. We try to average about, at least I try to average about 2/3. But one root might be 3/4 and one root might be just above half. It just sort of depends on where it breaks apart.
So the ventral dorsal rhizotomy, or sometimes we call it a palliative rhizotomy, we do in the spastic quads, is kind of a newer thing for me, and maybe it's newer in the country. I don't know, but you've got some experience with that. What have your outcomes been?
Yeah. So the outcomes. So we've done lumbar, ventral, and dorsal rhizotomies, aka a palliative rhizotomy, on a number of kids. Some of them we did it because they'd never had a pump and families didn't want a pump. We've also done it in a number of families who had a pump and didn't like the idea of continuing surgery and continuing refills for any number of reasons, and said, if there's a way we can do this without all this upkeep, then we should do that. And I would say so far, every family, and again, these are generally children that you cannot ask them, do you feel better? So we have to go through the families. Mm-hmm. The families so far universally will say, my patient is easier to take care of in some way or another. The very first patient that we did called us about a month after the surgery, actually, and the patient was in pain. So we brought the patient in clinic, and ultimately what I think a large portion of that is that the patient's alignment had changed so much that his chair was hurting him because he was sitting differently because of the surgery. On the flip side, one of the interesting things as I've done more of these is that little things matter. And I think the most important thing to understand about a palliative rhizotomy is it is, by its nature, a loss of function surgery. So if you do a ventral dorsal rhizotomy, you will lose function. But the idea is that most of the kids who get it have so little function that they're really not going to lose anything. That being said, many of these children, even if they're not using their legs, may have little things that matter to them. So one of the families that was disappointed in the outcome was disappointed because up until the point of the palliative rhizotomy, one of the things that could always bring a smile to that patient's face was tickling his feet.
Oh.
And after the surgery, that wasn't a thing anymore because we were intentionally taking away a lot of that function. And that was very, that tamped the excitement for what otherwise was a successful procedure. That's why these children they're often like GM-FCS3s, right? The ones who 95% of their life are spent in a chair. Maybe some participation, but that participation from a physician's point of view might not be all that significant. But that participation might allow a kid to take a few steps to walk into the shallow end of a pool, or something simple that gives them. And so those kids, we've always erred on the side of just a dorsal rhizotomy. But the tricky part is they're often young. And what we anticipate is going to happen is they're going to grow. And yes, they can take a few steps now, but once their trunk becomes heavy enough, they're not going to be able to take those steps anymore because they don't have the strength underneath. And so this is a difficult discussion. These are the ones that we have to be the most careful with. And then there's one child so far who we have not only done the lumbar palliative rhizotomy on, but we've done the cervical palliative rhizotomy for.
Like simultaneously?
Not simultaneously, separately, only because he was the first one. And we wanted to make sure that we did the lumbar first, got the result that we expected because we've had experience with it, and then translated up into the cervical rhizotomy. And you're right, there's not a lot of literature available for the palliative rhizotomies, although there's more and more. There's especially little literature for the cervical rhizotomy. To my knowledge, the only paper that I know of was a series of 4 patients published out of the group in Chicago, Lurie in Chicago. So now in the one patient that we did it for, good outcome. But I can tell you that family was very enthusiastic about it. So there's a lot of potential bias there. That being said, we just signed a patient up to do both at the same time, and that'll be the first time that we do that. So
Wow.
it'll be a day.
The whole day for you.
Yeah.
With a lot of not much coffee.
No, we'll be in the OR.
Is it true that if you do the lumbar, sometimes it also helps with the upper extremity tone, or no?
Absolutely. I mean, I've seen it before. Multiple patients. I remember one patient we did this for, where we did the dorsal rhizotomy, had it planned to do an orthopedic intervention shortly after, same hospitalization. And then, which is a discussion unto itself. But patient woke up from surgery and said, "Look, I can open my hand. I've never been able to do that before." It was amazing. And I just think it just goes to show you that we don't understand everything about the nervous system. We understand very little. How that's possible, I have absolutely no idea.
So fascinating.
Yeah. And I've had more than a few patients say that, but the problem is I would never promise that, right? Because we can't predict it. But it has happened. So
Yeah, I feel like the pump, that makes sense because maybe some of it is going up, but yeah, to see that, it's fascinating.
Well, and even the surgeon who wrote that series of 4 patients with the cervical rhizotomies, I know him well enough that we've had conversations about this. And he said actually the very first patient that he did a cervical rhizotomy for, the only thing they could do with their arms, they could move their fingers just enough to play video games. And there was a long discussion about this because the expectation of the surgery was that there was going to be loss of that. And he wanted to be, at least, I'm putting words in his mouth, so I hope I'm representing our conversation. But he basically said, I went into that surgery having had a lot of discussions with the family about, like, you might lose that. And are you okay with that? And the patient came out and could play even more.
Wow.
Like gained function, which is, I don't know that we know how to explain that.
That's wonderful.
There was ventral, that was a dorsal ventral.
Yes, you do a dorsal ventral up there as well.
Jeez.
Yeah. You can do either, it turns out. Having done one in the technical part is not all that different from many other surgeries that we do. It's not, it's more the patient selection that's mysterious. So.
That's actually like really good research study if you think about it, because you have such a good tangible outcome. Like I used to be silver medal, but now I'm like gold medal plus surgery. So it's like right away.
The hard part is like we don't know if that's really going to be a gain of function for most people, right? Most people, we think it's going to be, because we're still cutting ventral roots. So
Interesting. Wait, if you do the cervical,
you cut both.
Will the lumbar be better? The lower body better?
Oh no, that part I doubt it, because we're cutting roots, not.
Yeah, that's
but
true.
Again, I would say the same thing about cutting roots in the lumbar spine. How does the arm get better? No idea.
Yeah.
No idea.
Mystery.
Yeah.
With the dorsal ventral, which seems to be a pretty new thing, and I've got a number of patients who I think would benefit that, and I would probably choose over a baclofen pump, but that would be a discussion with the family. But I would imagine there are a lot of adults that could benefit from that as well. Would you agree?
Yeah, I think so. I mean, we, as I mentioned before, we as a practice, my partner specifically he has done a dorsal rhizotomy for somebody in their 6th decade of life.
Wow.
And maybe a little bit more difficult postoperative course for sure. But the result was still quite good. And I have to say that the result is often, when I say good, it's often because the patient tells us it's good. A lot of these spasticity surgeries, the objective change isn't as good as what the family tells you it is. So then the question is, how do you actually measure that? It's super subjective, right? But at the end of the day, the family is the one taking care of the patient. So if they're the ones telling me that my family member's life is better, then I personally care less about the objective, like, oh, you can get the ankle to a certain degree of flexion, or you can get the leg to a certain degree of extension. Like, I care less about that. I care mostly about, have we achieved the goals that the family want? So
that makes sense. So for after the surgery, then we work I think all of your
Which
patients,
surgery?
after the SDR for
Yeah.
these little kiddos,
Yeah.
they come over to Mary Free Bed for intensive rehab.
Mm-hmm.
What does that kind of look like in the inpatient setting? I know, Doug, you see quite a bit of them.
Well, they're like 3 to 6 year old cute kids who the therapists never want to discharge.
Mm-hmm.
So they stay forever. But no, they get, it's inpatient rehab, so they have to get at least 3 hours of therapy, and they get more than that because there's rec therapy and music therapy and art therapy but sometimes they need nap time too. So it's a busy time, and how much can they tolerate? Sometimes you gotta slow down or gradually pick up the pace. But it's a lot of therapy, and a lot of it, I think the strength gains are probably slower than like the relearning how to move muscles, and kids can do that a lot quicker than us adults. Um, so they make a big jump in inpatient rehab, but then we transition them to outpatient and continue with outpatient because we want to keep improving their motor skills with this neural system that's been disrupted in a good way. So I think it's, in the right kids, it's a great surgery. Um, some of these kids, when I explain where I think a pump and a rhizotomy would both be reasonable, we explain the options. And in my experience, the parents usually will strongly deviate to one or the other.
Okay.
And sometimes it's maybe not my first choice, but I think it's a reasonable choice. And I think our job is to help them make an educated decision for their child.
I think what's really cool about rehab after dorsal rhizotomy is I think a lot of the rehab things we do is going back to the previous function and what you did before. But I feel like this is different. You're learning a new skill, you're gaining new muscle strength and alternative ways to do it. And I find that really fascinating and encouraging. Like, how often do we get to do something like that?
Yes. How often do you intentionally cut or disable a portion of the central nervous system, or technically speaking, the peripheral nervous system? But still, how often do you get to do that and help people gain function?
Right,
So
right.
it's a unique surgery within neurosurgery for sure.
What about peripheral neurotomy then?
Yes. So this is something that I'm definitely a big fan of. I was lucky enough to train with Leland Albright at the beginning of my residency, and he was a surgeon, pediatric neurosurgeon, known internationally for his work. And one of the areas that he really helped drive was the use of pumps. Not only he was the one that wrote the books on intraventricular pumps for dystonia and all sorts of things. So he was a remarkable surgeon in that regard. And one of the things that I saw him discuss is that neurosurgeons, we are so used to, we have these dramatic things sometimes, traumas, brain tumors, whatever, but there's not as much focus on the things that improve quality of life. And that's really what spasticity care is, spasticity surgery is. And so he was a big advocate of these things, and he was a big proponent of neurotomies. But neurotomies are fairly uncommon. There's not a lot of people doing them, and there's a lot of reasons for this. That being said, neurotomies for the right patient, I think are fantastic procedures. So the ones that we've done them on, we've done seven patients, 9 nerves. So a few of the patients have had both sides, specifically at the tibial nerve. And these are for people who have deformity of their ankle or of their foot, so that their equinus, their foot pointed down, and equinovarus feet as well, rotated in, so that, but that's all they have. Or if that's not all they have, it is the predominant thing that they have by far. Like everything else just kind of pales in comparison to it. So this is a surgery you can do. It's the same concept as a rhizotomy. The idea is to take one nerve root, split it into component parts, cut a certain percentage of them. But instead of doing it in the spine, near the origin, where you can get the roots for the entire leg, here in a tibial neurotomy, you expose the roots that go to the medial and lateral gastrocs in the soleus muscle, which are the flexors of the foot, right? The plantar flexors of the foot. And so you find the branches that go to these roots, it's those because you stimulate them, and then you cut a certain percentage. What percentage is ideal? We don't know. The published literature suggests, again, as long as you leave 10% of the root intact, even if you lose function, which you almost never do, but even if you do, you will regain it in time. So for these kids, this is a surgery that you don't need an inpatient stay. They come in, they get the surgery. It takes about 2 to 2.5 hours. They walk out. Pain is pretty minimal because we don't go through a muscle. We don't make any bone cuts. The nerve is fairly easy to find. And for the right patient, it works great. But one of the interesting things about it is that when I first started doing them, I expected the deformity of the foot to improve. My experience has been it doesn't. The kids, one of the kids that stands out in my mind, I mean, I remember all of them because it's such a small group, but one that stands out basically said at the age of 7 had never been able to participate in, regular soccer leagues or sports with peers because that patient would trip and fall because of their foot deformity. So had tried serial casting, had tried Botox, had tried baclofen, like for different reasons, none of these things were working. The serial casting worked, but then within a month of the cast coming off, the deformity was right back where it was. So had gone through all the conservative measures. And so then the question was, what do we do? Well, a rhizotomy, not a great option because we don't want to impact the entire leg. We just want to impact the plantar flexors of the foot. One option would be do a spine surgery where you go specifically to the L5 and S1 root, because those are the ones that are predominantly there. But all of those muscles get supply from multiple roots, right? It's not just L5 or just S1. And that's a spine surgery with risk of cerebrospinal fluid leak, as small as it might be. Because honestly, and I've been here for 10 years, we've been doing rhizotomies since 2017 was the first one, if not then 2018. I've only ever seen one cerebrospinal fluid leak. It almost never happens. That being said, there's no risk of CSF leak if you do this in the leg. There's no spine surgery if you do this in the leg. It's an outpatient surgery, not an inpatient surgery. So in any event, this patient, we had never been able to play sports. We've decided, okay, you've tried all the conservative things. I was very clear to them that there's limited evidence for this. There's one surgeon in Utah, Dr. Mahan, that's publishing on this. There's one surgeon in France that's published on neurotomies. His series, Dr. Sindow, was of 250 patients, but it was neurotomies all over the body, not just tibial neurotomies. Mm-hmm. And they were all in adults. So up until recently, there was no published pediatric literature in this. So I made that clear to the family. We said, okay, great, we're going to do it. We did it. So then I brought her back about a year later. And to my dismay, walks in, still has equinovarus foot deformity. And I'm looking at this, and I watched the patient walk in because that's like the whole exam for this patient is watching them walk. I immediately was sort of feeling, disappointed. But then I started talking to her, and she had been playing sports, and she'd been doing all the things that she could never do because she functionally could now run without tripping all over the place. So even though I couldn't physically see it, and I have videos that, I can put them side by side, and you almost can't tell. You can if you look close, but you almost can't tell the difference between pre and post-op. But the patient will tell you it's made a huge difference. And that's what I've heard from every single patient that we've done, which is that the stated goal of the surgery, to them, it's better. So it's either inability to walk or it's pain in the foot. And for every single patient, it's worked, even if I can't physically see it. Now, there was a recent paper published from a peripheral nerve group, mostly plastic surgery, and I forget exactly where it came from, about this surgery in pediatric patients. And it had a whole bunch of technical measurements, like here's how much the foot could dorsiflex, and here's how much the foot could rotate in versus pre and post-op, and all that stuff. And I think that's great. But again, I'm more on the side of like, I want the patient to get the benefit. And there is Dr. Mann in particular, who's the surgeon at Utah, talks about this subjective sort of patient score. And in my mind, what matters is, are we causing complications? It does not appear so. It's only been 2.5 years for the longest follow-up so far. But we have no patients with weakness, no patients with numbness. Now that's all tibial nerve. We just saw a patient recently, much more debilitated, who is having all sorts of difficulty actually treating a wrist. But part of the reason they can't treat the wrist is because the arm is locked in like this. And so we just signed that patient up for a musculocutaneous neurotomy. So we'll see. But I think, to me, all of this is aimed at increasing comfort. And I can have all these fancy instruments to show range of motion, and I can, gait labs and all this other kind of stuff. But at the end of the day, what really matters is, can the family say, my child's life is easier? And if it is, then the surgery has worked.
It's like the ultimate success, right? Mm-hmm. My life is better. My child's life is better.
That's right.
Yeah.
Well, and you mentioned doing the musculocutaneous nerve, which sometimes I'll do nerve blocks there, Botox. And it's surprising, maybe because we live in Michigan, how often I hear it's hard to put a long sleeve shirt or a coat on my child because they're always flexed.
Yep.
And that can help with that. And sometimes you don't even think about that until the parents will notice it.
Yeah.
And that's why too, I think it's good to have our group get together to discuss some of these kids, so we all have different experiences and can have different inputs and say, well, what about this? What about that? Yeah. To make sure we're making the best decision.
Yeah. And I think, the hard part is convincing the families, right? No family wants to come into a surgeon and you talk about the surgery. Here's what we're going to do. And then they ask you, how many of these have you done?
Yeah.
0. Mm-hmm. Right. So, I mean, I'm incredibly thankful to the families who've allowed us to do that. There was a first palliative rhizotomy. There was a first cervical rhizotomy. Mm-hmm. There was a first tibial neurotomy. And then now there's going to be a first musculocutaneous neurotomy.
Wow.
So I'm incredibly thankful to those families, because thereafter I can tell the family, here's what we've experienced. Mm-hmm. So I think patient selection is critical, and the families that have been the first, they've been the first because I told them straight up, I've never done this before. I've told them there's very limited evidence for this. Mm-hmm. Here's what I think is going to happen. Here's what the literature is. And they say, and they're very enthusiastic, like, great. I hear you. I hear you that you can't tell me about this, but we want to move forward. So I think it is pushing the envelope a little bit, but I think spasticity care has largely been limited to rhizotomy, dorsal rhizotomy only, lumbar dorsal rhizotomy, and pumps for the most part. Mm-hmm. And I think there's a lot more that we can do.
Is there an age where you do the peripheral neurotomies?
So actually, no, you can do them any age. So the data that we have, the series that are published, are all published in adults. And they're published not with the same indications. So we talked about the standard dorsal rhizotomy is a preemie IVA or preemie patient, maybe with some periventricular leukomalacia. But actually, most of the patients for the tibial neurotomies are brain injured patients from a trauma. Some of them are from a spontaneous bleed. Actually, very few of them are adults who used to be preemies and made it to adulthood. So, and there's, to emphasize the paucity of literature, there's one study from a group in Brazil that looked at the durability of these neurotomies. And in their study, their average follow-up was something like 10 or 11 years. Wow. And in only like 2% of patients needed a redo surgery. Everyone else, what they found, at least what they reported, was the benefit they had 10, 11 years later was as good as it was at the beginning.
Wow.
And that's all in adults. So actually, there's more evidence for this in adults than there is in peds. My feeling is I don't see why neurotomy in pediatrics is any different than rhizotomy, right? We just talked about earlier about rhizotomy being good to do early.
Mm-hmm.
We just don't have the evidence for it. And you don't start a new procedure by doing that right away. So, so far we've done all the tibial neurotomies in patients who failed all the other things.
Mm-hmm.
I bet you 20, 30 years from now, if we continue to study this, we will find that there's great benefit doing the tibial neurotomy early first, rather than making them fail all this stuff and do it later. Mm-hmm. The problems with that is we don't have any patients who've had a tibial neurotomy who then went on to need a rhizotomy. So what happens if you've had a tibial neurotomy on one side and then you find out, oh, shoot, they've got spasticity everywhere, and then they need a rhizotomy? What's going to happen to those people? We don't know. So
Yeah. I think...
Well, I was just going to say, we live this. We could talk about this for 2 or 3 days, but we got to wrap things up a little bit. Do you have one last question?
Oh, it wasn't a question. It was actually more of a comment. I think the fact you're really pioneering the field, right? You're pushing the boundaries. And the fact that the patients are saying yes, I think that says a lot about who you are as a surgeon, because that they're trusting their child and in your hands. And I think that's there must be such an amazing feeling to be able to provide that for these patients.
I think what it is that I don't try to hide the fact that it's new. I'm not interested in sneaking something, under the table. And I think if there's one thing I could point to that probably is the reason that they've been willing to do it, universally, the families who were the first, they were all very willing. They were very willing to do anything for their child. They were willing to be committed to the care that was necessary. None of these families are families that I had to worry about, are they going to actually bring their child to therapy or whatever. And then I think they were all understanding that medicine is as much, especially neuro, and especially in pediatrics, it's as much an art as it is a science. And we have limited science for some of the things that we do, but we do not have and never will have randomized trials for most everything that I do. So we will never have great standard evidence for almost anything that I do. And so I think making sure that they understand that I understand that, and that I'm not just recommending this surgery because I want to do another surgery. I think that's probably the main thing. Because otherwise I'm just setting myself up for not only failure, but really unhappy people. Right.
I really appreciate the thought. I mean, you almost sound like a physiatrist. I'm pretty impressed. So, but we're so happy to have you here in the area and taking care of our kids, and appreciate you joining us here and sharing your thoughts on what you do. Thank you so much.
Absolutely. Thanks for having me. It's been a pleasure.